Hello, everyone. Good morning. I have the honor of introducing my friend and long-term colleague, Dr. Lawrence Mbuagbaw. Dr. Mbuagbaw is a research methods scientist and epidemiologist. He is an associate professor at McMaster University, where he teaches courses in biostatistics, randomized trials, and evidence synthesis. He is also an associate professor extraordinary, or extraordinaire, of epidemiology and biostatistics at Stellenbosch University. He is the director of the Research Methods Center in the Research Institute at St. Joseph's Healthcare Hamilton, where he provides methodological and statistical support to other researchers. His HIV research focuses on drug resistance, the care cascade, and improving outcomes in vulnerable populations. Please join me in welcoming Dr. Mbuagbaw to the stage.
Good morning, everybody, and it is a great pleasure to be here to stand in front of you and talk today. Two things. If you haven't noticed, I am dressed like my profile picture, so you can recognize me. This doesn't happen very, very often. I would like to thank CAHR for hosting this conference in the lovely city of Halifax, and I would also like to thank the Epi and Public Health chairs, Shamara and Sergio, for inviting me to give this talk. I'd also like to thank all my collaborators, colleagues, friends, and communities who make HIV research worthwhile. In case you're curious about how you get a title, Professor Extraordinaire, what you have to do is to work for free. That is what is extraordinary about the role. It's not anything special. So I do have some conflicts to talk about. I've been working at McMaster and St. Joseph's Healthcare Hamilton for more than 10 years now. I do consultancy work for industry, for the WHO, for PHAC, and the Canadian Drug Agency. And I have received research support from CAHR, CTN, the Ontario HIV Treatment Network, St. Joseph's Foundation, and a bunch of other places. I also receive honoraria for the work I do from PHAC and from the Canadian Drug Agency. Up there, I have two land acknowledgements, and the reason why there are two is because I'm giving a presentation here in the territory of the Mi'kmaq people, but I live, play, and work in Hamilton, which is the territory of the Haudenosaunee people. So I would like to acknowledge both of these people, and also tell you a little bit about my journey to Canada and why this is an important talk for me to give. The first time I came to Canada as an international postdoc of the CTN, I came to a CAHR conference in Toronto. And several years down the line, here I am again giving a plenary talk. So it's a special moment for me. So again, thank you, CAHR, for having me for the second time in Canada. So today I want to talk about the current landscape of HIV in Canada briefly, and make some emphasis on the importance of collective action in addressing HIV issues and advancing research, and also try to identify some of the strategies we can use to sustain the progress that we've already made, especially in light of the current funding landscape. So if we look at the number of new diagnoses in Canada, I have data from 2023. I have seen the data from 2024, but I'm not allowed to share it yet, so bear with me on this. The main issue we can see here is that the number of new cases are increasing since 2022, and they are most concerning in Manitoba and Saskatchewan. If we look at the number and rate of new diagnoses by sex, you can see that there's an increase almost twofold in men compared to women. And if we look at the mode of transmission, by far it happens mostly by heterosexual contact, followed by male-to-male sexual contact, and then by injection drug use. So in 2023, 247 infants were born to people living with HIV, of which 5 were perinatally infected. So this is about 2%. Now, I would like to talk about some of the gaps in care, and then I'll follow this up with gaps in research, and then we'll talk about how we can improve some of these issues. In Canada, especially among vulnerable populations, a significant proportion of people are diagnosed late, and they get engaged in care very late. And this is most frequent with racialized communities and with marginalized groups. The big concern with late diagnosis is that it leads to worse health outcomes, delayed treatments, increased transmission risk, higher healthcare costs, and widening healthcare disparities. The late diagnosis and linkage to care is strongly tied to concerns and delays in accessing testing and prevention. Again, we are having challenges bringing point-of-care testing to people in remote and underserved communities, and also in providing adequate access to PrEP for marginalized groups, especially indigenous people, Black people, people who inject drugs, and transgender people. Likewise, we have concerns with the continuity of care. We have a lot of stigma and discrimination in healthcare settings, criminalization of HIV disclosure, substance use and sex work, and insufficient integration of HIV care with all the social influences on health, and mental health, substance use, and primary care services. There is also a concerning lack of bilingual and culturally competent services for French-speaking people who live in English-speaking provinces in Canada. The next issue, which is going to become a big one in the future, is the lack of support for people aging with HIV. We now have an increasing number of people living with HIV past their 50s and past their 60s. And we haven't yet sorted out how to manage their comorbidities and how to integrate geriatric HIV care in the kinds of care models that we have. There's also a lack of research on the services that are required and their long-term healthcare needs, especially in the light of issues like cognitive decline and frailty. Now I'm going to talk about some of the gaps in research which we could try to address together. Several groups are underrepresented, especially key populations. I'm referring to indigenous people, Black communities, LGBTQ people, people who inject drugs, people who are in prisons, and they're underrepresented in clinical trials, implementation studies, and most importantly, they do not sit at the decision-making tables, and therefore their voices are not appropriately heard, and they cannot influence research agendas. Likewise, there's limited community-led and culturally safe research. A lot of the HIV funding is not directed towards structural support for community-based research, indigenous-led methodologies, and research that integrates lived experience throughout the process. Further, there is a lack of implementation science and real-world evaluations. While we have a strong biomedical research infrastructure, there's a lack of real-world implementation studies or research on scaling successful interventions in diverse contexts, and also the evaluation of digital health tools for HIV care and prevention. We haven't sufficiently explored the benefits and harms of using artificial intelligence in HIV care, and this is an area in which we could expand. Further, there's inequitable funding and policy translation. We have discussed already, and everybody is aware of the funding concerns from the United States. But within Canada, there's limited and fragmented funding, especially for social and structural interventions. Our research findings are not always translated into practice and policy, especially those that are addressing the social determinants of health. There is a huge mismatch between funding and research. And we do research on the topics that are funded and in the people for whom it is funded. But we could do things differently. Now, one of the potential solutions is to do things together. There is a proverb, if you want to go fast, go alone, and if you want to go far, go together. So my call to you is for us to attempt to go together through collective action. Integrating epidemiology, clinical research, social sciences, community-based approaches, health economics, implementation science, behavioral science, policy studies, indigenous health systems, data science, biomedical engineering, pharmacology, ethics, and legal studies will all help to provide a more holistic picture of how HIV research to be. And I cannot emphasize enough how important it is to include the social sciences. We need to strengthen our community involvement as well. We should be partnering with people living with HIV, indigenous communities, racialized and marginalized people, advocacy groups, peer networks, healthcare providers, youth, elder representatives, LGBTQ organizations, and individuals with lived and living experiences to ensure that research, care, and policy are inclusive, grounded, and community-driven. I would like to propose that we continue the work of the regional networks while fostering cross-regional collaborations. The CTN is currently working with a decentralized structure and showing great promise in filling some of these important knowledge gaps. The local regional networks exist, but we could expand them further to include the groups who need this information the most. So we ask ourselves, how can we move forward? Because it doesn't just suffice to identify the problems, but we should also be able to propose solutions. So what are some of the key strategies we can use to sustain the progress we have already made in HIV research? The first one I propose is data sharing and integration. We absolutely need to build robust data repositories and be able to harmonize data across regions and link administrative databases. We need more political will to generate complete countrywide data. Other countries, such as Brazil, have national registries, even though they have a federal system. So the excuse of saying we have a federal system and therefore each region handles their data the way they want is not a valid excuse. I am aware of some ongoing work in this area where researchers at ICS are collaborating with the other groups like RAMQ in Quebec to merge data without actual transfer of data. So what they're doing is they are sharing model parameters for similarly built analytical models and merging those parameters, and they're getting similar results as if the data were shared. While these innovations are ideal, they require complex computing. And the best approach will be to find a solution to be able to merge data countrywide. We also should not forget the importance of capacity building. This is critical, especially for the communities who have an uphill battle against HIV. In this room today, I encourage every mentee to find one mentor before the conference is over, hold their hand, and learn from them. I also encourage every mentor to find one trainee and show them how to walk the walk. The next thing we need to focus on is equity-driven research so that we can address the needs of marginalized populations, regionalized populations, and those who face socioeconomic barriers. This is because we may solve the HIV problem collectively, but there will still be issues with these populations. Yesterday, I was giving a talk at the CTN meeting, and somebody asked me whether there's any evidence that equity-driven research leads to benefits. And when I got the question, I didn't have a good answer. But then I realized that is probably not the right question. We don't do equity-driven research to bring benefits, but mostly to prevent harm. And there's ample evidence of the harms that can be caused by not conducting research through an equity lens. The next thing I would propose is innovative research approaches. In the trial space, everywhere you go, you'll hear of platform trials, umbrella trials, adaptive designs, and that might be the direction we should be going in. But the truth is, the old ways haven't worked so well, so we should try something new. I'm not asking for us to reinvent the wheel. What I'm simply asking is for us to use winter tires in the winter and do fit-for-purpose research. You would note the conspicuous absence of items in the box that represents regional and national success stories. This is not because there are no items to put in the box. The success stories do exist. There are many of them. A lot of them are in this room right now, but these are not my stories to tell. If you want these stories, attend the plenaries, attend the oral sessions, view the posters. That box is empty to give more room for success. Now, there are several opportunities which we can leverage. And the first is strengthening equity-focused clinical trial infrastructure. It is not as challenging as it sounds. It requires a little bit more money, a little bit more commitment, but it can be done. We should also expand trainee and community mentorship programs, especially targeting people in underrepresented groups. Because when we assume that the HIV pandemic is over, the HIV pandemic will still exist in these groups, and they will need these researchers to continue holding the fort and to continue flying the flag. We also need to support interdisciplinary research. CAHR is an excellent example of bridging the basic sciences, epidemiology, and all the other fields together. And it is something we should continue. But we should also remember that early on in the pandemic, we discovered that HIV was not a biomedical disease alone. It was mostly a social disease. And therefore, we should continue looking into mental health, housing, gender-based violence, and how this impacts HIV vulnerability. Further, we should continue the advocacy for public education, public funding, and ways in which we can reduce stigma. I will show you further down how much stigma impacts access to healthcare and use of health services in Canada. So, in the next few slides, I'm going to talk about some of the findings which I have identified in my research and which have helped to formulate the arguments which I put forth just now. The AC study was a cross-sectional study of first and second generation Black people in Ottawa and the Greater Toronto area. The study included 1,380 people, and there was a survey on HIV vulnerability, a dry blood spot test for HIV testing, and an opportunity for data linkage. I'm going to talk about 4 of the papers that have emanated from this study. The 3 papers address 3 important questions. In brief, what barriers do Black people face in assessing PrEP? What factors are associated with HIV risk? And how does racism impact healthcare? We found that access to PrEP was influenced by fear, stigma, lack of information, lack of provider awareness, lack of cultural sensitivity, cost, and racism. And the risks of HIV are the usual that you would expect: socio-demographic factors. It was linked to age, employment, the language that they spoke, level of education, place of birth, and social capital. But most interestingly, with regards to racism, what we found was that it was prevalent in the healthcare system, especially towards Black people, and it reduced people's likelihood of getting tested for HIV. It was also associated with difficulties in accessing healthcare. And when you put all of this together, it led to low self-rated health among Black people in Canada. Earlier on, I spoke about large data repositories and linking administrative data sets, but this works best if we have cohort studies that can be linked to administrative data sets. And in the AC study, out of 1,380 people, we were only able to link about 115 people, which is extremely concerning because the way forward would be to work with large administrative databases, but this just wasn't possible. And what we discovered afresh is that there are sociodemographic factors and personal factors that influence people's willingness to share their data for linkage. And for those people who chose not to share their data for linkage, we asked them why. Most of the concerns were due to privacy, and sometimes it was because they were unable to do so simply because of their status in Canada. So a lot of the Black people in the study were either international students or refugees, so they did not have OHIP cards. And some people just didn't have OHIP to begin with. So these are all concerns which we must address. We must find holistic ways to ensure that even if we are moving forward with administrative data, the administrative data is complete and representative, especially of the people who need it the most. Some additional work I did with the Ontario Hospital Association and in their anti-racism task force was meant to identify the extent of underrepresentation of ethnic minorities in clinical research, and also to identify strategies to improve their representation. So we found that it was important to enhance collaboration between researchers, clinicians, and the community, and to also improve our study designs. We can design studies that are fit for purpose. We can design studies that are intended to recruit the people that we need to recruit in our studies. We should also enhance our recruitment efforts, promote equity, diversity, and inclusion in research, and improve patient awareness of the importance of research and the role they can play by contributing. So with all this in mind, I do have a call to action and a request for all of you. And I strongly believe, together, we should envision a unified coast-to-coast approach to HIV research and care, one that bridges expertise, centers equity, and strengthens outcomes for all. Through continued collaboration among diverse stakeholders, sustained strategic funding, we can build a resilient, inclusive research ecosystem that drives innovation, empowers communities, and advances health equity across Canada. Thank you.
Thanks very much, Lawrence, for a great presentation. We have some time for some questions. So do we have any questions before we give you this? Please.
Thank you very much, Dr. Lawrence, for a great presentation. My name is Bakita Kusada, a social scientist, PhD student. Once upon a time when I was young, the chair of the global network of young people living with HIV. So my question is around young people and growing up with HIV, and also the point that you made around aging. I was wondering if you had any thoughts about that population who may not be considered older people, but will also be aging with HIV from teen, infancy, 20, mid-40s and onwards, and if there are, and your just general thoughts about aging with HIV amongst a cohort that's considered young people and young adults and the gaps there. Thank you.
Thank you very much. That's a very important question and an important area of research. And I am aware of some of the research going on in this space, especially with regards to transitioning from child care to adult care. and how this works and whether people stay engaged in care and the interventions that can be used to promote transition to adult care. So a lot of this work is being done in the pediatric space, but it is an important priority because there is a notable drop in retention in care among youth transitioning to adult care.
Yeah, hi. I know that, okay, my name is Michael Davies Cole. I'm with HEAL Nova Scotia, formerly known as AIDS Coalition Nova Scotia. One of the things I've noticed in the Atlantic provinces is that I think it's fantastic. We're doing all the talk with youth, and I really champion that and push that. But as a person living with HIV, what I notice is that we seem to be dropping the demographic of older people. I get the feeling like, yeah, we've done that. Your time is gone. Gone. See you later. Now we're working with youth, or we're focusing more. This is within healthcare here. And so I'm just wondering what dynamics, what things you've done or seen in working towards elder care within HIV, within minority groups, because within Nova Scotia, we've had a long look at non-minority groups in older care, or more of a look, but we have very little in anything minority. I mean, women, people of color here is very lacking. One of the things we always say is we don't have the numbers. We'll never have the numbers. We still have to look. Yeah. So, thank you.
Thank you. That's a very relevant question, and it is one of the knowledge gaps which I identified. We really don't have that much data or haven't done that much work on aging in HIV. And when you cross that with ethnic minorities, you have an even smaller group to work with. But it's an important area of research, and I think something should be done.
Yeah, and thank you for that. And I bring it up, and I bring it up to everybody in the room too. It's not just, we say that every meeting. We don't have the info, we don't have the info. Could we please start looking at the info? Like, people are, put it in perspective, people are hidden and missing within our demographics because we keep talking about getting the info, but we never get the info. And part of the pushback, I know, within healthcare is like, there's not enough numbers. There will be never enough numbers. So we have to go, okay, we just got to do with what we got.
Thank you very much for that wonderful talk. My question might be hard this early in the morning, but one of the things that you commented about is having a federal approach to HIV care.
Yes.
And this is something that we hear over and over again, similar to in our research as well. But given that funding is competitive, how do we actually work the system to work together instead of essentially fighting each other for the same pot of money, going after the same sort of target population or intervention or implementation, and we're really not working together, especially with the comments of the last speaker, where we're having huge funding cuts because of U of S population or U of S policies. So how can we work together when funding is still competitive and doesn't allow us to work together?
Thanks. So I think groups like the CTN are doing a good job in trying to bring people to work together. But I also believe that a government is responsible for the well-being of its people, and certain things which belong in the realm of social good should be the responsibility of the government and not researchers. These things include healthcare, education, and most importantly, data about the populations they serve. So I would emphasize that this should be a federal initiative. There should be federal interest to put everything together, and it should not be on us.
Yeah. Thank you.
Hi, Lawrence. Congratulations for a great talk.
Thank you.
Mona Lutfi, Women's College Hospital. I'm so glad that you brought up in your work and your slide the impact of racism on these health outcomes. And of course, that fits into the relation to intersectional discrimination with HIV-related stigma, sexism. We have the expert Carmen here on that. But can I ask you, And we heard from Winston Husbands last night also about the importance of racism on health outcomes and its relation to HIV care and research. What do you see the future, like what can we do as a research portfolio to further the research about racism's impact on health outcomes and HIV? What is possible for us to study in terms of not just relationships, but implementation science, interventions, and so forth?
Thank you. That's a very loaded question, so I will try to unpack it as best I can. I think the issue of racism is multi-layered and can be addressed at different levels. And it is not only about individuals interacting, it's about individuals working within systems that control and mandate the things they can and the things they cannot do. So in this light, I will share some of the work we're doing at the Black Expert Working Group of PHAC and explain one of the ways in which we're moving the dial forward. So one of the key issues with race data in Canada is that there is not enough of it. Less than half of the data we have on HIV has ethnicity or race appended to it. And this is problematic because it makes it hard for us to show credible information about the impact of HIV on ethnic minorities. So what we're doing in the Black Expert Working Group is that we are looking at the reasons why it is not collected. And some of the reasons include, from the provider side, not having the competence or the skill or the confidence to ask somebody about their ethnicity. And on the patient side, no understanding of why people are asking for their ethnicity. I came here to do an HIV test. Why do you want to know my ethnicity? So what the Black Expert Working Group is doing is we are working on scripts that healthcare providers can use to approach people and to explain to them exactly why it is important to collect this data. We are also working on categorizing ethnicity data and race data so that it is captured in a comprehensive way. One of the key challenges we have, obviously, is that some provinces collect the data and don't report it, and others don't collect it to begin with. So we are making strides in terms of talking with all these other regions to see if that information can be collected. Now, if we have that data, we will be able to say exactly what the concerns are, why some groups are not accessing care and why some groups are having difficulty using the services that are available to them. And then from then, we could start trying to develop interventions, which would include training on cultural safety. And all of this needs to be grounded in the recognition that healthcare is a human right, and therefore everybody is entitled to their fair share. Thanks.
Thank you so much for your talk. And as CAHR goes to Winnipeg next year, I invite everyone to go to the Human Rights Museum, which actually doesn't reference health as a human right to date. So that's something that we could also talk about in Canada and how that's not actually at our National Museum. Rodney Russo, I'm the chair of the board at the OHTN, and I'm just going to invite your reaction to a comment rather than give you a question. So the conversation around aging and racism is super interesting to me. And it strikes me that we have conversations around not having enough data around racialized folks who are aging, when at the same time, racialized folks often don't get to age. So think, for example, about Indigenous folks who have a life expectancy 15 to 20 years younger than the general population. Well, if we study people living with HIV who are aging as those 60 up and above, you're just going to have fewer people who are Indigenous who get to even make it there, irrespective of HIV. So how do we critically engage with the questions that we ask to make sure that we aren't discriminating in the way that we do the research? So I guess I do have a question in there, but it's more of a comment than a question.
Yeah, well, thank you for that, and I appreciate it. And I'm going to share that when I started doing HIV research, or research in general, I looked up the life expectancy of a Cameroonian male, and it was 49 years, which means I should be dying very soon. And that is problematic, right? The discrepancies in life expectancy based on age. But in terms of having data on diversity, there is a massive study with close to 50,000 people in Canada. It's called the Canadian Longitudinal Study on Aging. this study is sorely lacking in representation of minority groups. And the main issue is the way the studies are designed. We can design studies to capture this data, and we can build cohorts so that we can capture data administratively. If we say we don't have the numbers, what we are saying is we don't have the numbers in research. But the old people, the elderly people from ethnic minorities exist. We see them every day, and we see their data in HIV research. Right? We know they are there. The question is, how do we engage communities? How do we encourage them to be part of these studies? And one of the things I mentioned in my talk on EDI yesterday at the CTN was that people participate in studies conducted and led by people who are like them. And I gave the example of the CHAP study, which was a cardiovascular trial with a huge impact on reducing heart failure and stroke, in which community members who were elderly recruited other community members, measured their blood pressure, and when it was high, referred them to healthcare. So I think we can use innovative research strategies to answer some of these questions. We just need to have purpose and the will to do it. And the next thing I would say is we have groups that fund research on aging, and we have groups that fund research on HIV. I haven't seen any funding that puts the two together. And that might be an important area where we should focus. Does that help?
So Lawrence, I'm going to ask you a question about methods and research on methods and developing methods. Because we know within our field in HIV, we know that our sample sizes can tend to be quite small, and especially in places like Atlantic Canada, where our rates of new diagnoses are among the lowest in the country. The population sizes are small, and I'm coming from the smallest province in both population and landmass. And so my question to you, and I'm asking you this question as a methodologist and a biostatistician, how can we support the development of more robust methods for dealing with smaller sample sizes? We know in our discipline of epidemiology, we really do privilege large sample sizes. Yes. But the reality in doing HIV research, and especially if we're doing equity-focused HIV research, where those populations tend to be smaller, and in regions like Atlantic Canada, those populations tend to be much smaller than in other parts of the country. How can we overcome those methodological challenges?
Thanks, Shamara. That's a very good question. There are several responses to that. In addition to the fancy statistical things you can do, like reweighting your sampling and oversampling populations, there is also value in just collecting the data, because every data point matters, and it can be used for several studies beyond yours. So if you have 10 people, another person has 10 people, another person has 10 people, you end up with 100 people. And the lack of large sample sizes is part of the reason why I encourage the nationwide collection of data and merging of the data. Because if you have data from the country, it'll be hard to say we're working with small numbers. There may be few from the Atlantic region, but when you add the numbers from Ontario and from BC, and then we get a sample from which we can make more credible inferences. And the other thing I want to add, and Carmen is going to love this, is that we can do more social science work with the small numbers. We can do qualitative research. We can do other forms of research that do not rely on population-level inferences and large sample sizes. That's where I would take it.
Good morning once again.
Thank you.
So my name is Neha. I work with one of the ASOs, and you guys have been talking about data, right? But I see that we as small organizations do cater to individuals directly, and then you said you have a project, sometimes research institutes, they work in funding that aging part or the other. So where is the gap in between a research institute getting connected with an organization which is dealing directly with the people, and why that collaboration is lacking on the bigger scale? Because we see that these organizations exist. They do have data. Yes, we do report that data. But we do have people to talk about and maybe cater to your studies. So where do you think that gap is of not having that collaboration. Thank you.
I just need you to clarify the collaboration between researchers and aid service organizations. What gap are we talking about?
Working, I don't know. So no, I'm talking about the gap as in like, we have these organizations specific in the areas, for instance, that we are catering. I'll talk about my own organization. So we serve like a very big region, Halton, Hamilton, Brantford, Haldimand, Norfolk, right? So we have that, but then we come to know, okay, fine, there is a program in Hamilton Health Sciences, they might be doing some research. So, and that is like, like what I'm talking about, like how to kind of bring the academicians and this particular thing together to be able to produce something more productive, or maybe something which is working on the ground and beneficial for the people who need the service.
Thank you. That's an excellent question. And I think conferences like this are the appropriate forum for people from diverse disciplines to talk to each other. Now is the time for you to talk to other scientists from Hamilton. There are a bunch of them here whom I don't see in Hamilton, but I see in Halifax. So we should probably get together and come up with some plans for how we can optimize the data. But the short answer to your question is that my personal opinion is that the relationship between the scientists and the ASOs is sometimes an abusive relationship, because we go to them only when we need them. And then when we don't need them, they don't hear from us at all, right? So there is value in fostering those long-term collaborations and working with them even outside of the research space. Thank you.
Thank you very much, Lawrence. That was a record number of questions. That was awesome. Thank you very much.
Thank you.
Thank you. That was great.